A very good morning, distinguished guests and esteemed colleagues. It is with great pleasure and sense of profound privilege that we, Dr. Alaka KS, Assistant Professor, Department of General Medicine, AJ Institute of Medical Sciences,
and I, Dr. Rohan Archie, Senior Resident, Department of General Medicine, AJIMS, stand before you today as your Masters of Ceremony for this remarkable conference, Hormones in Harmony. We extend a warm and hearty welcome to this conference organized by Endodiab Charitable Society.
Endodiab Charitable Society is a chain of clinics located in Mangalore, Calicut, Kannur and Perindalmanna. Endodiab Charitable Society is a non-profit organization involving endocrinologists throughout India. This year, in the Endodiabcon conference, we are covering various fields of endocrinology, including diabetes, thyroid, reproductive bone, and pediatrics with more color and flavors.
Speakers of national repute from institutions spread all over India have converged here to update our knowledge. Conference will be held simultaneously in two separate halls. This is Hall A, Bandarkar Hall in ground floor, where we will address topics concerning diabetes.
Hall B is Amini Hall, which is in the ground floor on the opposite side. We'll address topics concerning pediatric and reproductive endocrinology along with thyroid and bone health. We request you all to assemble in respective halls. We'll start with the first session in another 5 minutes. We shall start with the first talk of our day. First session will be by Dr. We'll invite our chairpersons to the stage. Dr. Raghav Sharma, Dr. Sudhindra Rao and Dr. Sunil Kumar sir. Please occupy the dais, sir. Dr. Raghav Sharma is presently the Professor and Unit Head of Department of General Medicine, K.S. Hegde Medical Academy, Mangalore. He has vast experience of teaching with UGs and PGs for past 28 years. He has around 45 publications to his credit. He has been external examiner in various universities. He is a lifetime member of various professional associations.
Dr. Sudhindra Rao, Professor and HOD, Department of Medicine, K.S. Hegde Institute of Medical Academy, Mangalore. And Dr. Sunil Kumar, Professor of Department of Medicine, Srinivas Institute of Medical Science and RC, Mukka. We would like to ask the chairpersons to grace the stage and chair the session.
We now invite our first speaker, Dr. Abhay Sahu, to talk on stringent glycemic control, advantages and disadvantages.
Good morning, ladies and gentlemen. A warm welcome for each one of you. On behalf of chairpersons here, we thank the organizers for giving this opportunity. As we are all aware, diabetes is so prevalent and all of us are involved with treatment and follow-ups and particularly giving the holistic approach for their care. In this context, in today's sessions, very good topics have been selected by the organizers. For the first session is being taken by Dr. Professor Saho, which is related to the stringent glycemic control, advantages and disadvantages. So all of us are aware, diabetes control is very difficult because it has got multiple factors involved with this. Genes play a role, environment plays a role, psychological aspects play a role, drugs play a role, and diet plays a role. With all these various parameters in place, we would like to hear from our esteemed speaker regarding this concept, and we'll be hearing to him shortly. Over to you, sir.
Thank you, respected chairpersons, my dear friends and colleagues. So, at the outset, I am thankful to Dr. Ganesh and the whole team for this beautifully orchestrated conference. So, I am the opening batsman. I have been given the assigned topic, stringent glycemic control, the advantages and disadvantages. So, people will discuss about the introduction of the topic, understanding what is stringent glycemic control, what are the factors influencing stringent glycemic control or glycemic control, what are the evidence, early evidence for this stringent glycemic control, what are the disadvantages, and what is the paradigm shift in this approach to particularly beyond glycemic control, the model care in diabetes management and take-home message. So if you will see the earlier studies, we know that long-term complications increases as the glucose level increases. So that actually tries to make sure that if you keep near normoglycemia, probably you can prevent complications. We have large RCTs, DCCT, UKPDS, all have demonstrated that there is a reduction in microvascular complications once you are going for a stringent glycemic control. So that is the reason why many clinical guidelines claim that HbA1c between 6.5, less than 6.5 is better, and it is wise to keep below 6.5. But now recently a lot of evidences has coming. It's not necessary to keep only blood glucose normal. There are few drugs itself, they have their own propensity to give benefit, and a near normoglycemia is good. There is no need of going for a very stringent glycemic control. We'll discuss that part. So there is a paradigm shift from the glucose-centric approach to various organ-centric or complication-based approach for particularly management of diabetes. So what is stringent glycemic control? If keeping a HbA1c less than 6.5, this involves frequent monitoring, adjustment of diet, exercise, your own feeding pattern, medications to maintain that. But standard glycemic control is, if you are keeping between 7 to 7.5, it is considered as a standard HbA1c control or standard glycemic control. So there are a lot of factors actually involved influencing this glycemic control. There is lifestyle plays a critical role. Then there are what type of agents, drugs you are using for managing that is important. Patients' education and engagement is important, and also there is some population specific factors like those who are young people, short duration of diabetes, having low BMI, probably they need tighter control, and patients who are receiving in the tertiary care centers have a better control in comparison to the primary or secondary care centers. What are the earlier evidences? If you will see that chronic hyperglycemia is directly linked to micro and macrovascular complications, whether it is CKD, proliferative retinopathy, neuropathy, amputation, stroke, everything is directly related. And first trial is actually DCCT, first examined the intensive glycemic control with keeping a blood glucose between 70 to 120. What they found, and fasting between 70 to 120 and postprandial less than 180, they found there is significant benefit is there if you are using that. Then second most important trial came, this is Kumamoto. Kumamoto actually over a period of 6 years, they found that if you are going for an intensive glycemic control, you are reducing the complications by 10 to 25%. And the threshold was HbA1c less than 6.5, fasting less than 110 and PP less than 180. Then UKPDS has clearly shown that, of course, if you are tightly controlling the absolute risk reduction of everything, if you are combining together, it is only 3.2% reduction. But if you are separating micro and macro, probably for microvascular complications, there is benefit. But for macrovascular complications, they did not get any benefit from the beginning. This is the UKPDS, the intensive, the upper one is actually those who are having conventional, and the lower one is intensive. There is a 0.9% HbA1c reduction. And this is the important slide. If you see stroke, PVD and diabetic related death, the grade 1, what I have shown, there is no significant difference in UKPDS, but for the microvascular complication, they got significant benefits. So, of course, if you are doing a tight glycemic control, you are giving benefits of particularly improvement in the microvascular complications. This is the DCCT, what shows that in comparison to conventional intensive treatment, significant HbA1c good reduction, and again the blood glucose control is good. But what they found that in comparison to conventional, there is a 57% reduction in particularly all sort of complications, stroke, myocardial infarctions and CV death. So again, DCCT has again given a clear-cut idea mandate that tight glycemic control is required. Initial UKPDS did not give any benefit for the macrovascular complications, but later on when they followed up those people after 10 years, this is the legacy effect, what they found, even if along with microvascular complications, there is some benefit for the myocardial infection, there is some benefit from all-cause mortality. So again, if you are tightly controlling from the beginning, probably after a decade or after 10 years, after 15 years, you are going to give benefit to the patients, and there is significant improvement will be there. Again, the UKPDS on the left side, UKPDS is showing 25% benefit is reduction in the microvascular complications, and DCCT showing 42% reduction in the microvascular complications. So what we learned till now, that if you are probably doing for a stringent glycemic control, then reduces the risk of complications. There is specifically microvascular complication benefit is there. Of course, some studies are showing there is microvascular complications and it improves the quality of life, and also there is long-term health benefits like potential lifespan will be longer, and also that can lead to reduction in the healthcare costs. But after that came some other trials like ADVANCE, ACCORD, VDAT, they came. What they shows that ADVANCE trial showing that only retinopathy is reduced, there is no other advantages if you are going for tight glycemic control. Only retinopathy is reduced. And again similarly ACCORD, if you will see, they also did not get that much benefit from particularly tight glycemic control. Rather than what they found that probably the risk is increasing, the mortality is increasing if you are going for tight glycemic control. So this is the ACCORD, ADVANCE and ACCORD. If you see the intensive group means the HbA1c was less than 6 and the standard group is HbA1c less than 7. So in both ACCORD and ADVANCE, the intensive means the HbA1c is less than 7. Lower side, no need to think this is the what are the drugs they have used. But the upper line, it is most important. HbA1c less than 6, standard is HbA1c less than 7. So what they found, if you will see the HbA1c reduction, if you will see the fasting plasma glucose reduction, both are very good in the intensive group. We have no doubt, very good. But if you will see the complications, you see the first one is combined major micro and macrovascular complications. The second one is major macrovascular complications, major microvascular complications and death. There is no difference. So almost there is same in both the groups. So what they found that even if you are going for a tight glycemic control, probably you are not giving that much benefit. This is the baseline characteristic advanced studies overview. The only problem here is that if you will see that those people who are actually participated in advance all are having an average duration of diabetes is 13 years and the average age was 65 years. Probably this might be the hindering factor that if you are taking a 65-year-old person having a duration of diabetes quite a long, probably you are not going to give much benefit instead of starting a tight glycemic control from the beginning. So that might be one factor, but still they did not get that much benefit. So again, if we will summarize ACCORD, ADVANCE, VDAT, you see for the microvascular complications, only in the ADVANCE they got for the significant for nephropathy, but again for retinopathy they did not get, and ACCORD, VDAT did not get anything. In the see the lower part, effect on the macrovascular complications, nothing. So all trials, ACCORD, ADVANCE, VDAT, all showing even if a tight glycemic control did not give any significant benefit to the patients. But if you see the hypoglycemic part, you see in the intensive arm, there is a quite significant hypoglycemia is there in comparison to the standard arm. So that shows you are not going to get any benefit, but you are giving a significant hypoglycemia to the patient. So in that way, probably a intensive control is not that much important for particularly today's view. Let us see what is happening if you are doing the intensive control. What are the studies till date? What is showing that there is intensive cardiovascular complications, specifically the high risk of left ventricular dysfunction compared to non-diabetic patients, and benefits is there will be reversal of remodeling. The ischemic myocardium regeneration will be better if you tight glycemic control, and also the post myocardial remodeling will be better if you are going for a tight glycemic control. But what are the meta-analysis of ACCORD, ADVANCE, VDAT showing? Only there is a 15 to 17% reduction in the non-fatal MI. And if you will see the age to taken consideration, probably young people, those who are newly detected people, they are going to much more benefit. Elderly people might not get significant benefit. Of course, those are having peri-operative patients, diabetic having CABG, diabetes having any sort of infections, probably they need a stringent control, and this stringent control or tight glycemic control gives a short-term benefit to them. If you are considering stroke and heart failure, again that is debatable. There is controversies that whether you are going to with a tight glycemic control, whether you can get some benefit or not. So again, there is some debatable or there is controversial data regarding whether tight glycemic control really gives some benefits or not. You see, this is the meta-analysis of 5 studies, UKPDS, Proactive, ACCORD, ADVANCE, VDAT. What's shown, if you think about that any sort of coronary heart disease, probably little bit benefit is there, it is 0.85, so giving little bit benefit, not that much. If you in the upper part, if you see the particularly stroke, then again it is around close to 1, so not that much benefit. And if you see the all cause mortality, again with intensive, it is almost same 1, so no benefit. So that means all, even if a meta-analysis of trials is clearly showing, even if you are going for a tight glycemic control, you are not going to give that much benefit, for particularly in those complication point of view. This is against evidence from the systemic review. If you see the last red one, microalbuminuria and the reduction in the photocoagulation, these are the two important things what with intensive diet control, all studies are going equal result, similar result, that there is benefit. But if you see the initial part, end-stage renal disease, renal death, blindness or clinical neuropathy, it is again some studies is giving positive results, some studies are giving negative results. So again, it's not all studies are in the same way to tell that tight glycemic control gives significant benefit. So again, this is the interference from the CBOT trials, that all elderly patients with long-standing diabetes or existing comorbidities don't benefit from the intensive glycemic control. But it is sure that if along with diabetes, if we are targeting other things like dyslipidemia, hypertension, obesity, along with blood glucose control, probably you will give maximum benefit to those patients. So this is the analysis, meta-analysis of all, from all cause mortality of different studies. Again, all is showing there is no improvement in the mortality if you are going for tight glycemic control, well, in comparison to the conventional glycemic control. So disadvantage, as I have discussed, there is risk of hypoglycemia with tight glycemic control will be significantly high. That will lead to actual impaired quality of life. There will be stress and anxiety for the patient. Again, if you are going for a tight glycemic control, that need for a frequent medical visit, the frequent blood testing, potential higher medical cost of the medication will be significantly high. And the most important part is that it costs around 20 to 30% higher cost to the patient, and as I have discussed, the risk of hypoglycemia will be far much more higher. And this is clearly showing what is, you are not actually, sometimes a lot of the time we did not detect hypoglycemia. This is asymptomatic episodes of hypoglycemia. What has shown clearly, you will see that all patients of diabetes and type 1 and type 2, it is close to 50% people have some sort of asymptomatic hypoglycemia, which we are not detecting clinically, or sometimes people did not actually reported us with particularly symptoms. But what is the problem? If you are having any episode of hypoglycemia, elderly people, that can lead to QT prolongation and sudden cardiac death. The risk of cardiac events significantly increases during that particularly specifically hypoglycemic events or hypoglycemic event. So if someone is remaining little bit higher blood glucose, probably not that much significant, but if someone is actually going hypoglycemia, that is important. So there is a paradigm shift that people see the all CBOT trials what recently, LEADER, SUSTAIN, CANVAS, DECLARE-TIMI, REWIND, all those trials. If you see the intensive group or the treatment group versus the placebo group, both was having equal HbA1c. They did not go there, it is around 7%. They did not go beyond that. But still, they are getting benefit. It is the benefit of the drug. It is not the tight glycemic control, it is the benefit of the drug. So, CBOT were designed to test the cardiovascular safety of newer all glucose-lowering drugs having similar HbA1c level. This variation in the study endpoints attributes to the study drug, not to the HbA1c level. So, all those actually, because in the both the groups, in the treatment group, in the placebo group, both are having actually equal HbA1c, still they are getting benefits. So, mean HbA1c in the intervention arm of CBOT with cardiovascular renal benefits was consistently around 7%, supporting there is moderate glycemic control is sufficient, there is no need to go for a stringent glycemic control. Again, these are certain controversial glycemic strategies. If you see the Leuven trial, advocates near normal glycemia, no need to going for a tight glycemic control, like a nice sugar, blood glucose between 140 to 180 is okay. Then recent review analysis, critical ill patients, studies showing moderate control is safer. Of course, if someone is going for a surgery, perioperative period, a tight glycemic control is better for particularly those who are having surgery. So, major guidelines recommends target HbA1c less than 7. Again, ACE advocates between less than 6.5 is okay. And so, guideline emphasizes control of blood glucose along with blood pressure and cholesterol, prevention of delay of complications, and maintaining a healthy quality of life. So, there is now it is clear that there is no clear benefits of going for intensive control over a moderate. Only that there is a 9 to 20% relative risk reduction of non-fatal MI, more consistent with surrogate markers like those who have microvascular complications like microalbuminuria, macroalbuminuria, photocoagulation, they are getting some sort of benefits. But the problem is there is a 2 to 3-fold increased risk of hypoglycemia. There is additional harm like increased risk of adverse drug reactions, polypharmacy, treatment burden, high cost to the patients, all are with particularly with this thing. So, the most important approach is balancing glycemic control, that glycemic target should be tailored based on the patient factors. patient education and support is utmost important, and you can use technologies like CGMS so that you can monitor hypoglycemia in those group of patients. So that for that there is a model, 3 model. First thing is shared decision making. You discuss with the patient, you see what is the actually a real role of the problem with the patient and try to adjust what will be the best blood glucose control with the patients. So this is the therapeutic decision making. Identify the aspect of the patient situation and then work according to the address the need of the patient. That is the shared decision making for specifically for the management of diabetes. The second most important is that is should be minimally disruptive medicine, that is MDM. The goal is prioritize the patient's life and health goals, and there is a tool that that is instrument for patient capacity assessment, that there is a questionnaire. From that you can assess what is the capacity of the patient, what is the actually risk of complication in the patient, and that will give us what sort of medication you can plan. The third most important is the chronic care model, so that a multidisciplinary team approach should be there, and that will implement and that will give the best result to the patients instead of going for only a tight glycemic control and leaving hypertension, dyslipidemia, or other things actually separately. So if you see that stringent glycemic control offers a significant benefit but possesses a risk. The advantage is the reduces risk of microvascular complications, the potential lower the risk of some other options, and may improve long-term health outcomes, particularly those who are younger and short duration of diabetes. The disadvantage is there is increased risk of hypoglycemia, there is high treatment burden along with the impact on the quality of life, and may not be suitable for patients having limited life expectancy. Moderate glycemic control is clearly evidence showing that HbA1c around 7 is better, along with good newer drugs which can give cardiovascular renal benefits. They should be used, and majority of the guidelines recommends HbA1c around 7% is okay. However, the approach must be individualized, balancing the benefits and risk, like glucose lowering regimens should be tailored to each patient's need and balancing the benefits and risk ratio. Considering the relaxing targets, the patient with significant comorbidities or high risk of hypoglycemia, this should be there should be little bit much more relaxed things should be given to those groups. With this much, these are the references I have taken from that. With this much, I am finishing my topic. Thank you.
As is now open for discussion.
Yeah, for actually before going to the which insulin, for ICU patients, that is two important things. Whether patient is in a surgical ICU, whether patient is in a medical ICU. Those who are having surgical ICU, a tight glycemic control is better, 110 to 140 is a good target. But those who are having medical ICU, probably 140 to 180 is a good target. There is no need of going for a little bit stricter control for those group of patients. Regarding Dr. Mohan's question, what type of insulin you are planning to use? A lot of the time, actually, what the now guidelines is telling, if someone is on multiple small feeds, like those who are having RT feed or small feeds, you can use short-acting. There is newer short-acting insulin. They acts very quickly, and there is also their effect goes very rapidly. So multiple subcutaneous doses of very quick short-acting insulin is good. But a lot of the time you will get there is persistently those who are on steroid or any additional drugs. There is a persistent elevated fasting is there. So they are actually nowadays having a long-acting basal insulin. They also works very well. You can give a single shot of long-acting basal insulin. That also works very well for specifically those group of patients.
So now with this, what happens to the pharmacotherapy in pre-diabetics?
Yeah, actually, it will see again, pre-diabetic is totally a separate topic. So if you are thinking about the pre-diabetics, we have now ample of studies that probably for the pre-diabetes or for the what are the diabetes prevention program, whatever stop NIDM, DPP, what clearly they have shown that the lifestyle modification is the best thing for particularly for pre-diabetes, for prevention of development of diabetes. But what the author has last shown, because if you are going for lifestyle modification, probably you are giving the prevention by at the range of up to 58 to 59%. But what if you are using metformin, if you are using acarbose, it is at the range of 38 to 39, 40%. So what the author has given that if you are going for a lifestyle, probably sustaining that lifestyle for a quite long period is difficult. So it is wise to give some medications if someone deciding. And nowadays we have actually GLP-1 receptor agonist and also SGLT2. They have also shown clear-cut benefit if you are using in the pre-diabetic. So we have ample of drugs now, they can be used in the pre-diabetic state.
Sir, how do you define stringent and moderate glycemic control? What I have seen in the studies, they differ in their definition.
Yeah.
So,
actually,
how can you compare the studies?
Actually, I have shown in my first slide that probably what there is actually they have taken all guidelines, they have separately taken stringent and
Yeah.
guideline. But what I have shown in the accord advance, less than 6 is stringent glycemic control, less than 7 is actually the conventional group. The stringent group is less than 6 and less than 7 is the conventional group. So there is almost a 1% difference is there between stringent and conventional group. So you can take that much.
Okay.
Thank you, sir, for the enlightening talk. We now request our chairperson, Dr. Raghav Sharma, to hand over a token of appreciation to our speaker.
We now call upon our next speaker, Dr. Umesh Kumar Garg, to talk on current trending